Too late?
You tell me when. You give me the finger. Okay, she gave me. Okay, we're live. Welcome back to Labor, Health and Social Services, where we meet again to move on with our agenda. We're on to item number 6. Senior Services Resource and Care Coordination. LSO is on the agenda and Donna approaches. Welcome. Welcome, and we hope you had a great lunch.
All right, good afternoon, Mr. Chairman and members of the committee. You may remember that back at the April meeting, the committee requested LSO do some research on area agencies on aging and long-term services and supports provided by senior centers to older adults, and also care coordination of those services. So I prepared this research memo that you'll find in your meeting materials. I want to first say a thank you to the agencies, the Department of Health and the Department of Family Services and the Governor's Office. I relied on them heavily for the information in this report, and they all were very helpful. So thank you to those 3 offices and agencies. So this research memo starts off by talking a little bit about what community-based long-term services and supports are, and their services to allow adults to remain in their homes and communities as long as possible. They include things such as personal care, home health, home modification, transportation, meal services, adult day services. Many older adults lack the resources to pay privately for these services, and they must rely on federal and state programs. This memo summarizes the programs that are available in Wyoming. And if you look at the top of page 2, there's a table that presents the 2 federally created programs, the Wyoming Community Choices Waiver, which falls under the Medicaid Home and Community-Based Services programs, and then programs under the Older Americans Act. Wyoming also has 2 state programs, the Home Services Program and the Wyoming Senior Services Board Grants Program. So if you turn to page 3 of the memo, it gives you more information about the federal programs, beginning with the Medicaid Home and Community-Based Services Waiver. The waiver for older adults and adults with disabilities is called the Community Choices Waiver. If you turn to page 4, it lists the services that are available under that waiver. The Department of Health contracts with approximately 120 providers across the state to provide those waiver services. And of those 120 providers are about 22 Wyoming senior centers who provide 1 or more services under the waiver program. If you turn to page 5, there's information about the Older Americans Act, which provides funding for community services that many senior centers deliver. The act was passed in 1965 and amended in 1973 to establish what are called area agencies of aging, which are local or regional organizations that provide systems of coordinated care to older adults in the agency's planning and service areas. The 1973 Older Americans Act amendments provided states with the option to establish 1 or multiple planning and service areas for these OAA services. Wyoming chose to form a single statewide planning and service area. So Wyoming State Unit on Aging, which is the Wyoming Department of Health's Aging Division, functions as an area agency on aging for the entire state and contracts with senior centers and other local providers in each of Wyoming's 23 counties to provide the OAA funded services. Title III of the Older Americans Act provides funding to states for 4 types of community level services. And if you turn to page 6 of the memo, it lists what those services are. There's supportive services, nutrition services, disease prevention and health promotion services, and caregiver support services. Then starting at the bottom of page 6, the memo talks about the 2 Wyoming state programs. The first being the Wyoming Home Services Program, which was established in 1987 to provide community-based in-home services to seniors and adults with disabilities who were at risk of premature institutionalization. Generally, the individuals who are served by the Wyoming Home Services Program do not meet the financial eligibility criteria for the Medicaid Community Choices Waiver Program. And at the top of page 7, there's a list of what services are available to older adults and adults with disabilities under the Home Services Program. The Department of Health contracts with a single provider in each county to provide the Wyoming Home Services programs. Most of those county providers are senior centers, but in some counties, they may be hospitals or other nonprofit organizations. Bottom of page 7 is where the memo talks about the Wyoming Senior Services Board Grant Program, which was enacted in 2003. Under this program, grants are awarded to eligible senior centers throughout the state to supplement community services they provide. To be eligible for a Senior Services Board grant, a senior center must receive federal funds under the Older Americans Act Title III supportive services or nutrition services programs. And then on page 8, the memo addresses the issue of care coordination. So as you can see, there's here in our state, there's a variety of programs, a variety of funding streams to provide these community-based long-term services and supports. So individuals who are trying to access these services, are often having to try and figure out, where to go for the services, how to apply, and how they can access maybe overlapping services or intersecting services. This is true everywhere, not just in Wyoming. So beginning in 2003, at the federal level, the Federal Administration for Community Living, the CMS, the Centers for Medicare and Medicaid Services, and the Veterans Health Administration launched an initiative for states to create what are called Aging and Disability Resource Centers, ADRCs. Funding was provided to states to create these ADRCs, which would serve as a resource center where individuals could learn about what long-term services and supports are available and receive help with applying to those programs. That ADRC initiative over the years has evolved into a broader, what's called a No Wrong Door System initiative. And if you turn to page 9 of the memo, it explains what the No Wrong Door concept is. So that envisions that states will create a single statewide system where the multiple agencies involved in providing these services will coordinate, so that regardless of what agency an individual or a family seeking services for their loved one might contact, they can access information and one-on-one counseling about the available options. The federal government did provide grants to states to develop state plans for no wrong door systems. In 2014, grants were awarded to 23 states, and additional grants were given out in 2015 and 2022. To sustain these no wrong door systems, the federal government encourages states to blend a variety of funding sources. And one tool they're trying to promote is what's called Medicaid administrative claiming. The memo talks about this on page 9. Medicaid administrative claiming allows states to draw down Medicaid funds for administrative activities performed on behalf of potential Medicaid enrollees. And I provide an appendix that talks more about Medicaid administrative claiming. So, currently 24 states, including some of our neighbors, are performing Medicaid administrative claiming for no wrong door or ADRC activities, and an additional 15 states are in the planning phase. So Appendix E to the memo provides more information about no wrong door funding and a map of the states that are doing Medicaid administrative claiming. On page 10, the memo provides some information about the AARP Long-Term Services and Support State Scorecard. This is something that the AARP prepares every 3 years. They compile and analyze data from all 50 states and the District of Columbia. On the most recent scorecard from 2020, Wyoming ranks 33rd in our overall long-term services. If you can see the map of the United States and how we compare with other states, we're in the 3rd quartile in terms of our system performance, long-term services and support system performance. And at the bottom of the page, you can see how Wyoming ranks across 5 different dimensions. So affordability of long-term services, choice of setting and provider, quality of life, support for family caregivers, and effective transitions. At the top of page 11, you'll see if you dive into the Wyoming data, which I've attached as Appendix F to the memo, you'll see that in terms of our no wrong door functions, our care coordination functions, we currently rank last. We're 51st on the scorecard. So then, and then the final part of the memo, starting on page 11, is what Wyoming is doing currently as far as no wrong door efforts. So we did in 2012 receive a 3-year federal grant to launch an Aging and Disability Resource Center. That was a 3-year grant. When the federal grant expired, there wasn't continued state funding and the ADRC was dissolved. The Department of Health did partner with the University of Wyoming Center on Aging to create an ADRC website that people could go to for information, but there was no longer a center that was staffed with individuals called navigators who, could provide options counseling to older adults and their families. By last year in 2022, the governor's office, the Center on Aging, and the Department of Health and Department of Family Services recognized that there was a need to reestablish an Aging and Disability Resource Center. So the Department of Health and the Department of Family Services pooled some ARPA funds that each department had received, and they launched a 3-year pilot ADRC program. They're currently contracting with Wyoming 211 to staff an ADRC call center with a navigator who can provide resource referral and coordination services. Wyoming 211 began providing these services in May of this year. The ARPA funds will expire in September 2024. The Department of Family Services told me that Wyoming 211 wants to continue providing the ADRC navigator services and is hoping they can do so with grants, fundraising, and corporate sponsorship. And then the last page of the memo, page 12, provides information about another pilot program here in Wyoming, the Family Resources Center project. Family Resource Centers are community-based centers that provide referrals for services to individuals and families from birth to death. There's something that the governor's healthcare task force identified as a means to address gaps in human service access here in Wyoming. So a program was launched just this past year, a 3-year program that's being managed by the Wyoming Children's Trust. And again, ARPA funds are being used to fund the Family Resource Project. The project has two primary goals. The first is to provide grants to Wyoming communities to establish family resource centers, and the second is to create a statewide network to provide technical assistance and best practices to those community family resource centers. Beginning this month, September, Wyoming counties and tribes may apply for those grants and give some information about what the grant amounts are. And with that, I'll stand for any questions.
Many questions. I'm sorry, I was drifting there. I have a question on Appendix A. It's the Wyoming Senior Centers that provide Medicaid community. I'm assuming that in those counties that are not listed in that appendix, that those are the counties, and I ask because two of my counties are not listed on there. They're being provided by someone else other than the senior service. Is that correct?
That would be my understanding, Mr. Chairman. Not all senior centers in the state are community choice waiver providers, but many, the ones listed in Appendix A are, but it's not a requirement of senior centers.
Okay, questions, committee? Answers, committee? Comments, committee? You're off the hook. Thank you very much, Ms. Ship. And that was a lot of work. That's a lot of information.
Thank you. Well, again, as I said, I relied heavily on the agencies to provide this information, so I do thank them.
And I would strongly suggest the committee, as you may be on this committee moving forward after next year, put this in your file somewhere. It will come back to be useful. Okay. Anybody wish to comment on that presentation or on that information? Ms. Davis.
Good afternoon, committee, Chairman Baldwin, committee members. I'm Jen Davis, the Governor's Health and Human Services Policy Advisor. Thank you to Donna for doing that great work. It was really comprehensive. I just want to give you just another quick update on the last bullet point that she talked about, the Family Resource Centers. As Donna mentioned, that those grants will become available this month. As of today, 20 of our 23 counties have submitted a letter of interest for the funding to either strengthen their current family resource center or to develop one. So just wanted you all to know that there are still 3 counties who have not put in a letter of interest, but are expressing verbal interest in that. So they're helping them get information together. And it looks like we'll probably have all 23 counties submit an application, as well as the potential from both of the tribes. So just wanted to give you that additional information.
Thank you for that information. Committee, any questions for Ms. Davis? I suspect we'll see you again before the end of tomorrow. Thank you very much. No questions. Thank you. Anyone else wish to comment? Comments? Yeah, we do have a hand raise or somebody online. Oh, my co-chair failed here.
Yeah, I'll log back.
I'm sorry, I can't see the screen, so. Okay. Can you hear me, ma'am?
Hello, can you hear me?
Oh, there you are, Carmen. Go ahead, introduce yourself and go ahead and speak to the committee.
You bet. Mr. Chairman and committee members, my name is Carmen Rideout. I'm representing the Hub on Smith Sheridan Senior Center and also the Wyoming Association of Senior Center Project Directors. I know time is limited, so I'll keep this very short. Thank you so much for taking a closer look and interest in the services and supports for older adults and their families in our state. The memo that was just presented was excellent. I just returned from an excellent conference in Laramie, organized by the Wyoming Aging Division and the Wyoming Council on Aging. And it is very clear that an increased investment in community-based services is an overarching strategy to help people stay healthy and well and living at home for as long as possible. We support the work and efforts being made to expand the Community Choice Medicaid waiver. We also support the continuation of funding for the Wyoming Home Services Program, and also the exploration of the PACE Light or PACE Medium, which will be discussed later in your agenda. The No Wrong Door concept too is something that we see every day here, at least in our senior center. And we created our own little local No Wrong Door here in Sheridan by combining some of the funding that we received from the Older Americans Act, some grants from ARPA from DFS, and then some private foundation dollars. And the call center that 211 is doing is really great work, but there also needs to be a face-to-face contact, especially with some of our older adults that need that person-to-person care. So anyway, we support efforts to increase that kind of work as well. So senior centers and other community-based service providers are really anxious to be at the table as we work together and strategize for the needs of Wyoming senior citizens. So thank you very much.
Thank you very much. Any questions for Carmen? My committee is having a post-lunch quietness. Thank you very much for coming and visiting us today, Carmen.
You bet.
Anyone else
Thank you.
online? See no one. Anyone else in the room? Again, seeing no one. Committee, any comments? No legislation to work with here. Any comments you wish to have? Hey, all right, let's move on with that. Thank you again, Donna. That was very good, Bishop. That's good information. Information which will be beneficial to the committee down the road for sure. Okay, let's move on to item number 7, long-term care issues. I see 3 people listed on here, Department of Health, Eric Boley and Carolyn Pasnoff. If you'd all like, whoever's, we got 4 chairs. Department of Health, go ahead, sir. Reintroduce yourself and let us know what's on your mind.
Mr. Chairman, members of the committee, Lee Grossman, State Medicaid Agent. Like to introduce you to, on my left, my colleague Elizabeth Forslund, who is the administrator of our home and community-based services at the Wyoming Medicaid Agency. And without further ado, I will also turn it over to Mr. Fuchs.
Good afternoon, members of the committee. Mr. Chairman, my name is again Franz Fuchs, Policy Analyst, Department of Health. We're here today to brief you on the slides starting in 24. So this is a project relating to long-term care, specifically a 1115 waiver that we're pursuing the direction of the legislature, and just wanted to give you an update on that. Given time is about an hour left before your next engagement, I'll try to get through this quickly. So as you can see on slide 25, we have been directed and through footnote 17 to our budget to negotiate with the Centers for Medicare and Medicaid Services on the operation of a narrowly tailored long-term care waiver with the intent of expanding long-term home care and community-based service to individuals who may not currently qualify for such services under Medicaid. And I'm just reading the bold part there, the bottom line. So what is a waiver? Slide 26, the word waiver refers to looking at certain provisions of the Social Security Act and trying to waive them. So generally speaking in Medicaid, those waivers have really looked at expanding services or looking at alternative service delivery methods or expanding the populations covered. So for example, our home and community-based waivers, which Elizabeth is the expert here, and I would urge you to send all the hard questions to her on any of those. We operate that through a waiver. This 1115 waiver is a little different. 1115 waivers are known as demonstration waivers or experimental waivers. And you can see on slide 27, these are really about testing different ideas on Medicaid. And these ideas really have to be in the judgment of the Secretary of Health and Human Services to be likely and assist in promoting the objectives of the Medicaid program, which per section 1901 of the Social Security Act is to assist states in furnishing medical and rehabilitative assistance to eligible individuals. The other two main requirements for 1115 waivers is they have to be budget neutral to the federal government. So we have to demonstrate that this waiver will not cost the federal government any more money than they would without the waiver. We also have a very significant public notice and transparency requirements. And the demonstration really has to be rigorously evaluated to see if it works. The whole point is really testing out a new idea. So we need to be able to know whether it works. So what is the problem we're trying to solve with this particular 1115 waiver? As you all know from our last presentation at this committee in June, we project the pace of home and community-based services in Medicaid to slow. So this is kind of the main problem we're trying to solve. Right, we've gone from about 50% back in 2013 to about just over 65% of people being served in home-based settings in Medicaid today, but that will likely stagnate going forward. And so we're really trying to have more momentum to that trend. We think this is the single best policy lever to really try to improve people's experience with long-term care as well as contain costs for the state. So when we look at one indicator, if we're looking at one indicator to measure this problem, we're looking at the percentage of people served in home-based settings that require long-term care, right? And the reason it's going to slow is we have this demographic bulge, this baby boom cohort that's moving upward in age. And over the projection horizon, so out to 2040, the baby boom will enter their prime risk for nursing home placements and requiring long-term care. And unfortunately, at older ages and older cohorts, the penetration for home-based services is much lower than for younger folks. So as we get this sort of growing bulge in these older demographics combined with the lower take-up rate means that while both nursing home and HCBS will continue to grow, they'll kind of grow in parallel tracks. And so the actual percentage of people served in home-based settings is going to be the same or stagnate. So really the purpose of this eligibility expansion is really to try to test out an idea, to try to give some momentum to that positive trend. And it's really the idea of trying to what we call intercept people. So imagine, if you're not aware of home community-based options and you're say, you have maybe small amount of savings in the bank, you wouldn't qualify for Medicaid. Your default may, when you start needing long-term care and you may not have family and friends, your default may be the local nursing home, and you may just automatically just end up there without really being able to consider many options, right? At that point, private pay for nursing home is around $100,000 a year. So you may not be Medicaid eligible before, but you will quickly become Medicaid eligible if you spend those assets. And so we have people that arrive on Medicaid in the nursing home already. And that is a missed opportunity to try to divert them from nursing home in the very beginning, from the first place. It's very much harder to get people out of the nursing home into community settings than it is to prevent them from going there in the first place. So really the idea of this waiver is by expanding eligibility on the margins of Medicaid, so relatively small movements on income, assets, and need, we want to try to intercept those folks, offer them home-based alternative, and then see through this demonstration whether or not we diverted enough nursing home stays to pay for the program. That's the waiver in a nutshell. So slides 29 through 30 kind of talk about the different expansions of eligibility. We're looking at limiting this to people over 65. We would waive asset recovery. Asset recovery is a big barrier for a lot of folks that are contemplating Medicaid. That's one thing we'd seek to, one big reason why we'd need the 1115 waiver. That's something we can't just waive normally. The services will be provided through the existing community choices waivers, the same provider network, the same services with some exceptions, which we'll talk about, and the same payment mechanisms. And then we'd evaluate this through a randomized controlled trial. So that is kind of the gold standard for really evaluating any kind of program. The thresholds we're looking to increase are the eligibility thresholds for long-term care. So on slide 30, we're decreasing that from 13 points to 11 points. That's a small 2-point decrease in the score that you're required to meet the threshold for long-term care. The LT 101 is a long-term care assessment that's performed by public health nurses on people that are requesting it. On the financial side, we would look at bumping up the income requirement from 300% of SSI to 400% of SSI. So on a monthly basis for a single person, that's around going from $2,700 a month to $3,700 a month. And then on assets, we'd increase that limit from $2,000 in countable resources to $10,000. So relatively small movements on each of these dimensions. The services would only be home-based options. So we're assuming that basically if this is eligible for people over 65 only, Medicare would be the primary medical service payer. And then the Medicaid would basically cover home-based services listed on that table on slide 32. So it's a very similar benefit. Anything on the table on the left would be covered. We would not cover things like assisted living facility, skilled nursing, and then case management to get people out of nursing homes, because the idea is this is really a diversionary interception program, and those higher levels of waiver services shouldn't be necessary. We're also doing this, quite frankly, to have some cost savings on the per person level so we can serve more folks with the same budget. And it's really key to mention that we're not including any medical benefits here. This is purely home and community-based waiver benefits in this waiver. Slide 33 kind of talks about the nuts and bolts. So we're recommending an initial budget of $5 million a year. This would be both state and federal funds, so you can imagine a 50-50 split. Our estimated cost of the service package on a per person basis is $1,100 PMPM. So with that budget, we can serve around 350 people. It's a relatively small demonstration project. If we did not have a cap on the number on the budget or the number of people we could serve, we would estimate around 1,400 people would ultimately enroll. And because that's 1,400 is larger than 350, we would therefore necessitate a wait list, right? We're going to have people that we can't serve. We're going to have to ration this in some way because the budget is fixed. At the end of the day, this offers an opportunity to study the program because we can sort of randomize off the wait list who receives those services. And that allows us to really rigorously study, okay, we offer these services to this group, and we can compare their experience to the control group, and we can see whether or not, how many nursing home stays were basically averted over that time period. So that's really the most rigorous way to study this. Is it working? Slide 34 just kind of gives you a quick choose your own adventure. So if $5 million is not the right number, you can see kind of roughly speaking how many people we could serve at X million dollars. So at the high end, if we wanted to serve all 1,400, we'd estimate we'd need a budget of $16 million. And then finally, the outcomes evaluation, just to wrap it up real quick. The idea is people would not be randomized forever. So everyone every month would have an equal shot of receiving a slot off the slot in this program. And so people may be on the wait list, but then receive a slot. And we would look at their experience on the wait list as the control group and their experience on the program as the treatment group. And so it's not like you're permanently, we flip a coin, now you're permanently on the wait list forever. It's every month we would, redo this process as slots open up. So you can kind of see on an example on slide 36, these people listed, kind of just a notional example of when people might be on the treatment group or the control group or both. At the end of the day, we're really looking at trying to model on the last slide, really how does being on the waiver versus the wait list affect that probability of transitioning from the demonstration to nursing home? There's a key probability there. And we'd sort of model that out and project out, had these people not receive services, here's what their experience would have been, here's how much it would have cost Medicaid, here's how much it would have cost the state and federal government, and here are the net savings or net costs for the program. So the evaluation will be rigorous, and at the end of the day, we hope to have some positive results. But I think it's important to note that this is a very small project. It's not we're not solving all the problems inherent with long-term care in this. The staffing shortage is very real. This doesn't solve this. This really just is a small movement on the margins. I just want to be really clear about that. So with that, I'm happy to stand for any questions.
Questions, committee? Senator Hutchins.
Thank you, Mr. Chair. Franz, can you go over slide 36 again for me, please?
Sure. Mr. Chairman, Senator Hutchins, this talks about it just gives a notional example for 6 individuals who the green is they received a slot on the waiver, and the red cell or C's that are on the control group. So T for treatment, C for control. So for example, Ulysses gets on the waiver of the first program. He's in month 1. In month 9, he moves to Florida. So he's leaves the program, right? So that experience on the waiver is what gets contributed to the data. And then William, on the other hand, is on the wait list for the first month, but he's lucky. On the next month 2, he gets a slot on the waiver and stays on it until month 12, and so on and so forth. So at the end of the day, you got poor Ambrose at the very bottom, applies in month 5, does not get a waiver slot, and stays in the wait list until month 9, at which point he too moves to Florida. So that's hopefully explains the diagram.
Follow up, Senator Hutchins. Go ahead.
Thank you, Mr. Chair. It's fun, but how do you get to be George?
Mr. Chairman, Senator Hutchings, George got the luck of the draw there. With his all randomization, right? So there's way different, when you have a wait list, there's different ways to assign those slots. One way would be first come, first serve. Another way would be looking at, highest need goes first. And this is just a third alternative, which is just an equal shot for everybody any given month. And they all have pros and cons and drawbacks and advantages.
Mr. Co-Chair.
Thanks, Mr. Chairman. So when you say move to Florida, do you mean pass away? Is that, I mean, that's a much more likely outcome than. It's not like they're on the wait list and then, oh, they get to move to some nice, they're probably not gonna either go into a nursing home or they're not gonna make it. Is that a little more fair?
Mr. Chairman, that's probably more realistic. Yeah, this was just for the purpose of the example.
My wife is in Florida right now. Yeah. Okay, Senator Hutchins, go ahead.
Thank you. Franz, is this the PACE program?
Go ahead.
Mr. Chairman, Senator Hutchings, no, it is not. This would be under the Community Choices Waiver Program. We have a brief on the PACE study after this.
Thank you.
And
Go ahead.
perhaps now or later, the difference between this and the PACE pilot we did 9 years ago is what exactly besides this is statewide where PACE is probably only 8 or 9 communities in Wyoming, but are there, I don't know if you want to address that now, or if you want to address it. If you do address it now, that would make me happy.
Sure.
Thanks.
Mr. Chairman, so the Community Choices Waiver is widely available throughout the state. It really is home-based services, and those service menu varies depending on the need of the person. The PACE program was only in Cheyenne or Laramie County. It really was more of a model that incorporated a adult daycare at the center. So people would be going to the PACE center every day, a couple times a week. There was also transportation included in that, meals, socialization, primary care, case management. So there was a lot wrapped into the PACE model. And then the real big difference is PACE was paid on a capitated premium basis. So it was a fully managed care product, that like an insurance product, right? We paid the PACE program a set premium every month, and they delivered all those services, all inclusive services, which included all the medical services that person might need. So whereas the waiver is offered entirely on a fee for service basis, we just pay a la carte for all the services that are delivered. So different model of service delivery, also different payment model.
Very good. Representative Penn, long time no hear.
Thank you, Mr. Chairman. Two questions. One, who are we paying? Are these senior centers or those types of things? And then two, do we have the ability to provide these services, giving staffing issues or infrastructure or whatever?
Mr. Chairman, Representative Penn, CCW providers are a bit of a wider network. There are a lot of senior centers, as you saw from the memo, that do participate as Community Choices Waiver providers, but there are a lot of non-senior center home health agencies, case managers, other entities outside the senior center network that do provide Community Choices Waiver services. So it's not just senior centers, but they do participate. The staffing issue is real for not only nursing homes, but the home-based sector too. So this waiver, we certainly do not want to give the impression this solves that problem. This is a very narrow, tailored expansion of eligibility for a very small group of people.
Follow up.
Thank you. If we didn't have the staffing issues, do you think that we have the infrastructure and the entities available to provide these services?
Mr. Chairman, Representative Penn, that's a good question. I think it varies widely throughout the state. Certain parts of the state have more capabilities than others. I think one feature that's important to mention, though, about the waiver is we do offer a mode of service delivery called self-direction, where the person themselves can hire folks they know to do some of this light services like chores, homemaking. And Elizabeth would probably, hopefully can correct me on if I'm wrong here, but that kind of compensates a little bit for some of those areas where providers may not exist in that community, right? They can, if the neighbor's willing to do some chores, that we can allow that person to employ them, and then we pay that person. Medicaid will pay that person. Those funds are self-directed, is what we call. So that helps a little bit with the shortage of credential providers, but it's not 100% substitute for it.
Further questions, committee? Seeing none. Thank you very much. Okay, a couple more names per on the list. Mr. Boley.
Thank you, Mr. Chairman, committee members, Eric Bullis, Leading Age Wyoming. And we talked about some of the issues that we're facing in long-term care. I think that's kind of what you're asking for is updates, but there are a few areas of concern. One of the biggest ones was just announced about 2 weeks ago. The Biden administration through CMS has implemented proposed rules that would create staffing minimums for our long-term care facilities. It's going to be a burden. There are some provisions in there where it will be phased in over a period of time, especially for rural areas. There will be some leniency, they say. But again, this is where the conditions of participation have been weaponized. And similar to the vaccine mandate that we were forced to comply with a couple of years ago. And as we talked about during the conditions of, or the certificate of need conversation, there are some real concerns about the ability for our nursing homes to survive. We are the second oldest population demographically in the country. And by the time this is fully implemented, we may be the oldest demographically. With what's going on in a lot of our communities with the war on natural gas and on fossil fuels, the workforce is diminishing. And so there are some real concerns about how we're going to meet that need, how we're going to be compliant. We also are worried about where these folks are going to come from. There are requirements for how many RNs and how many hours they have to work, how many CNAs per patient are going to be there. And we're facing some other issues when it comes to healthcare, when it comes to CNAs. And we've talked a little bit about this, and I would actually maybe ask the committee, maybe the chairman to sign a letter to our senators. Our nursing homes are surveyed annually, and during that survey process, they may or may not have a civil monetary penalty imposed upon them. When they receive up to $10,000 in civil monetary penalties, they lose the ability to train CNAs for 2 years. So we have a mandate right now from CMS that we have to increase our staffing, and then we have CMS removing our ability to train CNAs in our own facilities. There are waivers, and you'll hear about that, where we can bring other people in to teach in our facilities, but some of those are 100 miles from the next closest place. It doesn't make any sense. And so I have been working with Senator Barrasso to try and introduce legislation that would fix this, especially for our rural communities. But it may be beneficial if this committee would, or the chairman would sign a letter encouraging him to continue with that work. Some of the other things that we're facing, we've had issues with testing for our CNAs. The state has changed its testing company. We're having a hard time getting CNAs licensed quickly and getting their testing done. They're having to travel distances to get that testing. We're facing issues with temporary licenses for CNAs that are licensed in other states. We're facing issues with background checks, similar to what we talked about with nursing home administrators. So as we take a look at the staffing issue, there are just a whole bunch of different pieces and parts that make it more and more difficult for us to be compliant. And then I think it was Representative Hornick brought up the fact that we're seeing less admissions into our nursing homes, and we are. A lot of it had to do with the pandemic, but even now it hasn't rebounded, and we've talked about the need to have those economies of scale and have our occupancy rates at a higher level. And it comes down again to the staffing issues. That's really the 1,000-pound gorilla right now. And I don't know how we're going to fix that. We talk about what's happening nationally, but and it's all across the country. And with this new staffing mandate that has been proposed, and right now it's in the comment period, and we're pushing back heavily against that. But the way that it was pushed out, how quickly it came out, I'm hoping there will be some changes made to that, but it is a major concern to us. I would also tell you that our nursing homes right now are probably in some of the worst financial condition that they've ever been. And a lot of it has to do with the fact that they haven't had enough residents, increases in cost. We've seen inflation hit them really heavily. We've seen the cost of traveling nursing staff, which was necessary during the pandemic and continues to be necessary even with existing staffing levels. Many of them are considering alternatives. I have several of my nursing homes that are attached to hospitals that are considering decertifying their nursing home beds and converting them into swing beds, which would benefit the hospitals because they get paid at a higher rate under Medicare, but it's not necessarily going to take care of the Medicaid patients. And it's actually going to create I think a gap or a hole as far as access to care is concerned. So that's concerning. And we've actually had one closure. We have 2 or 3, I believe, hospitals right now that are on extraordinary or emergency funding to try and help them financially. Some are considering a sale right now. There's a large one considering being sold to a private entity. So it's just a really tough time for our long-term care facilities in the state. And I have real concerns going forward, how we're going to meet the demand and the need in our state. And I think the waivers, these programs that we're talking about, helping people stay at home longer, less invasive, less expensive care is great. And the longer they can stay at home, that's fantastic. But at some point, more than likely, they're going to require long-term care, and we've got to have facilities across the state to care for them. And even though we've decided to move forward with certificate of need, I don't think that's going to be the solution. New facilities isn't necessarily going to fix the problem if we don't have the staff, the ability to care for those that need help. I don't know if that's what you want. I just saw my name on the agenda, but hopefully that answers some of the questions that came up earlier, and I'd stand for any questions.
Questions from Ms. Bully. I have a quick question. You may not be able to answer it. Any idea what the retention rate is for our CNAs that we train successfully pass the test? What's our retention rate?
Turnover in long-term care is terrible. Going back to the days that I thought we were doing great in Kimmer, we still had over 100% turnover at times in our staff. I think I've seen figures like around 130% turnover. It's tough, and we're trying to do creative things. We're trying to get kids started in high school and have them graduate as CNAs and maybe look to nursing. We've been working with some of the community colleges to actually have kids as they graduate college come out with an LPN degree. And LPNs, for those of you who don't know, we've got RNs, registered nurse, we got licensed practical nurses, LPNs, which is just below the RN. For a period of time, the LPN program basically just ceased to exist. Hospitals weren't hiring on LPNs, and there was a move away from those. But right now we are looking at moving back to that. The unfortunate part is under this matrix that's been built for the staffing ratios. If we do employ LPNs, it's actually going to increase the number of required staff to meet the staffing ratio because of the RN hours. But if we could produce enough LPNs, it would take a lot of pressure off of the RNs and maybe help with some of the staffing shortages we're seeing in other sectors of the healthcare market. So we're trying to be creative, and actually have a meeting next week up in Casper at the community college to start looking at other opportunities and options to increase our workforce.
Thank you. Further questions, committee? Representative Penn.
Thank you, Chairman. You mentioned CMS requirements on staffing ratios, and then you were just talking about LPN ratios and RN and things. Is CMS the main one that's making those requirements, the main agency, or are there other agencies that are saying these are what staffing requirements you have, or is that an internal in-house thing generally, or what's contributing to what decisions need to be made on those staffing ratios?
Mr. Chairman, Representative Penn. So right now, CMS is driving everything. It's the new mandate. We've had to always report our staffing. We actually are required at our reception desk to post the hours of each position within our nursing home so that the residents and their families know. And we've been able to kind of adjust as the acuity levels are higher with our patients. And so what we're being mandated to do right now, we've always been able to do on our own and adjust as needed. But what's coming down the pike right now is all driven by CMS.
Further questions, committee? Senator Dockstader.
So on the swing bed situation, if some hospitals look to go to a swing bed, those that were in there under more extensive care, Medicaid, they can't, they're left out. They can't be a part of that, right? And under the Medicaid program, they probably signed off their home and other things to say that's where their money goes now, is to keep them in this retirement center. So that leaves a group that's just not taken care of.
Mr. Bowley.
Mr. Chairman, Senator Doxator. So obviously, if that happens, the nursing home has to make arrangements to place those folks, but there's a good chance it's not going to be in their own community. But yeah, so those that are in nursing homes that went through the spin down phase and got rid of all their assets so they qualified for Medicaid. Under swing bed, they'd have to have a qualifying stay or reason under Medicare to be admitted. And so, yeah, we could end up with large swaths of the state where there's not long-term care available for those.
Thank you. Go ahead, Representative Ward.
Thank you, Mr. Chairman. Mr. Bowley, my daughter is a senior in high school and she is studying, she will graduate with a CNA. In the syllabus, which I had to sign, it says that there are still some facilities that require COVID vaccination. Are you aware of what facilities those would be?
Mr. Chairman, Representative Ward, I'm not, no. I can find out if you want. Yeah.
Further questions, committee? Seeing none. Thank you, sir.
Thank you.
Ms. Pascal.
I always feel so low in these chairs. Mr. Chairman,
We'll get you a riser for next meeting.
well, I'd appreciate that. A cushion or something. Carolyn Passano, Wyoming Healthcare Association. And I truly appreciate the opportunity here. I have learned new things listening to others. And I just listening to the CNA, I saw where Pennsylvania has teamed up as a partner, the Pennsylvania Healthcare Association, which would be like ours, teamed up with the university, and they actually are doing a career model for CNAs, actually others in the nursing home. That is because of the many who have left the profession during COVID. It was such hard work, long hours, difficult work, and people died. And they are saying that they will give it 25% less in payment for going to school there. And it goes all the way through LPN, RN, and they also expect to train people to be administrators of nursing homes. This is a healthcare program. We certainly could be talking about that to retain our workforce. And we keep saying that word, and you're probably tired of hearing it. We are too. We can't solve that problem immediately. It is a very difficult one. And there is, as you know, a new group of young people who have had a different life and expect different things when they go to work. And we had one CNA that had been taken the course and was through with that training, went to work the first day and then absolutely just left in the middle of the day and never came back. It is a different world that we're living in. And I would say what I have experienced as an individual, that whole era is gone. And we are embarking on a new era. And we don't know exactly what it's going to be. But the changes are coming so fast that during COVID, 1 week, CMS issued, they did not call them rules. I call them rules. They issued two different things in 1 week. It just is on a gallop, and it's going so fast that sometimes it's hard to keep up. And yes, as Mr. Bowley said, the new CMS ratio rule will be very, very difficult, especially in a state like Wyoming that has the least population of the 50. I have spoken with the Department of Health, sometimes in jest and sometimes seriously. We can try many different things to do. One of the things that other countries have done, because their need is great and they didn't have the resources, the workforce, especially Europe, and France is probably the lead in that. Other countries, Spain, and the country that has gone the fastest and the furthest is Japan. They are using robots in nursing homes and for other things too. Here in America, robots are being used in white tablecloth restaurants. The ones that I have seen pictures of all have very pleasant and fun faces. And I've seen pictures of the people in nursing homes just laughing and throwing their hands up and having such a good time with their caretakers that are delivering meals, delivering an aspirin. And actually they were doing some dancing, and they had a robot that was doing kind of a jiggle around the room too. I would hope that one day the Department of Health would buy a robot and put it in one of their facilities and see how it works. And then perhaps we could all get a grant some way and help ourselves. I read where Dolly Parton has a $1 million program to give away books to children. And it seems to me if we're going to use juniors and seniors and get them into the healthcare profession or even as interns, that we should get a relationship with Dolly Parton, and that we would get books, and even a junior in high school who wants to be an elementary teacher could have a mentor of a teacher, and we could have the children who can't read come to a nursing home, and who would not want to read to a grandmother or a grandfather, especially if there was a four-legged in the room. It didn't matter if it's a cat or a dog. And children need help in learning to read. So why couldn't we be a part of that? I'm just throwing out ideas that what a nursing home actually could be, that maybe we're not taking advantage of at this time. I was just writing some notes to myself of things that seem to be practical and that we could undertake, knowing that our workforce is not going to improve very fast. And as I said earlier, ANI tells us that the elderly population is going to escalate, and we're going to be at the head of the list, at least in the top 5 of states with that escalating population. Thinking about the 1115 waiver, I'm very much supportive of that. I think it's a real idea that will be helpful in our state. looking at it from my eyes and knowing what happens to seniors, not only in the nursing home, but seniors that are living at home, when their health begins to disintegrate, it can go very fast. And that involves LT 101 waiver or test to see if they're ready to go into a nursing home. And I just hope that we have enough nurses, public health nurses, whomever would do the LT 101, not once a year, but keeping track of those people that are in that program, LT 101, and the 115 waiver, that those people would be caught right away and given help if it's a nursing home. What we don't want for the nursing home is an individual to come in so ill that they have to go to the hospital in the first month they're there. That causes additional problems for the facilities, the nursing home and us, the hospital and the nursing home. I don't know where we are going to end up in this era that we're starting in. It's going very fast for me, and I'm sure for those who are in it daily. We cannot succeed with what is happening in the CMS mandate, and it is a mandate. And there are different years for different aspects of the program. The most is 5 years. They all of those pathways along should be 5 years. This can't happen quickly, or we will have people that have no place to go. And we can't afford to have that happen. We must not. We're all in this together, and we have to find the right way. I guess the last thing that the federal government has so much power now that knowing that we need nurses, it isn't just Wyoming, it's all over the United States, that they have a hold on foreign nurses that could come in a lot, but they cannot get green cards. They put out this mandate that will finish November 6th this year. There are companies that have a program that could get us nurses right away. They're not able to do that. I worked for agriculture, as some of you know, and started a program which still continues. It's out of Casper. It's called Mountain Plains Health Services. It brings in cowboys, sheep herders, and irrigators. And they're doing it every month, every year. It's been going all this time. But we can bring in sheep herders from foreign countries, South America, Spain, wherever, but we can't bring in nurses. That makes no sense to me at all. And as Mr. Boley said, we have to engage our congressional delegation, very much in need of help from them. I'll quit there, and if there's anything I can send to you individually, I would be glad to do that. I won't do the Federal Register with the CMS. It's 89 pages or something, but I do have an overview that I can send you if that's the sort of thing you like. Thank you.
Thank you. Any questions, committee? I think some of the committee members would love to see that 89-page document. Or thank you very much, Ms. Pascal, for presenting. Okay. Any questions, comments, committee? We got one more topic to go and then we're gonna go tour a hospital. Let's do the PACE program. Department of Health, do you have something for us?
Good afternoon, Mr. Chairman, Mr. Co-Chair, just me this time. Just happy to give you a quick overview of the PACE study that we're working on still. This is on slides 39 of our omnibus presentation. Understanding you have limited time, we wanted to give you just a quick update of the bottom line, our initial findings. We do have a bunch of supplementary material, graphs and figures and whatnot that are going to be part of the study that I'm happy to get into if there are questions, but otherwise I'll just do a quick run through of the findings.
Great.
So slide 41 talks about the requirement for the Department of Health to do the study. The study is really looking, and you can see the bolded portion here is the possibility of reinstituting the program throughout Wyoming, considering the for-profit and nonprofit options and potential cost savings. So when you look at slide 42, we try to break this down into what we call specified and implied tasks. The specified tasks we read in this footnote are: one, what for-profit, nonprofit providers might be able to set up a PACE program in Wyoming, and two, what would be the potential cost savings from restarting the program. And implied in that is really these two other questions, which is really about rate. The two sides of the same coin, pun intended, right? So what rate are we willing to pay? Is the state willing to pay that is cost effective, that will demonstrate those cost savings? And then is this cost effective rate sufficient to attract providers? So the analogy that we have is kind of, think back to your college microeconomics course with supply and demand. The rate we're willing to pay is the demand curve. There's a supply curve out there of providers that are willing to take money and provide PACE programs. You can see on slide 43, we had a previous program that was one PACE program was provided in the state, and we paid around $2,200 per member per month for that. So presumably, if there's a cost-effective rate that's higher than what we were paying before, we may attract more providers throughout the state, right? If that supply curve, depending on the slope of that supply curve, it's just an illustrative example. That's not the actual supply curve, right? If the cost-effective rate, however, is lower than what we were paying before, then there would be less than one or zero providers that are probably willing to take it. So that's kind of how we thought about this whole, the real core of this study is kind of a supply-demand analysis, and kind of first tackling the question of what is a cost-effective rate, and then looking at what providers might accept that. So the study is basically complete. The analysis, I still have to write most of the actual text, but the analysis is mostly done. So we have these findings here. We'll submit that PACE study to you all as part of a package. We have 3 reports. We're calling it our Aging in Wyoming series. We have a part 1, sort of a primer on aging, which we presented to you at your last meeting, kind of talking about the demographic factors involved. We have the long-term care eligibility expansion as part 2. That's the brief we just did. And then this PACE study will make up part 3. So it'll be probably about 90 pages of light weekend reading for you all. So you can look forward to that probably in early October. So getting to the bottom line here, slide 45 are some of your recommendations. Our first recommendation is do not attempt to restart PACE. We do not believe that the previous PACE program had a cost-effective rate. And therefore, we do not believe that any providers will participate if we offer a rate that's lower than that. There are very few providers in the state that likely have the capacity to do PACE. It's a very, very intensive, administratively intense and complex program. They are essentially operating a full Medicare Advantage plan. So that's basically like offering insurance product. They have to contract with Part D for prescription drugs to have offer that. They have to have a network of specialists, a network of long-term care facilities. And so there are very few providers in the state, mostly larger hospitals, that could really do this, kind of pull this off, even if we offered infinite dollars as a rate, right? So the barriers to entry are very high. We also cannot guarantee that programs will never be cut. And I know talking to the provider that previously operated PACE, that was one thing they were looking at is we discontinued the PACE program. We essentially pulled out the rug from what they had invested, and that is once bitten, twice shy. So it is doubtful that they would like to participate either. And we have certainly not heard any interest from providers that are capable of providing PACE in setting a program up. The other main issue is that managed care generally is something that is, it has its advantages, but it's also significant disadvantages. It's administratively burdensome for both the state and providers. I mean, think a PACE provider has to pay every single claim it gets for medical services for its members. It's literally an insurance company operating out of a hospital office. I mean, that's a lot of administrative overhead right there. The state had a significant amount of administrative overhead. We had 2 FTE devoted to this program because of the oversight requirements and managing the tripartite agreement between the state, the federal government, and the provider. So that's 2 FTE were devoted to serving 150 people in Laramie County, compared to a waiver program that was about 3,000 people right throughout the state that was, slightly larger as far as full-time employment. So it's administratively heavy for both entities. It's very opaque to the state as far as what we're getting for our rate. We're paying a premium, an all-inclusive premium. It's very hard to know if that premium is fair. The only reason we really know now that it was not cost effective was because we discontinued the program and we saw what we were paying immediately after we discontinued the program, and people transitioned to the settings that they would have been served in otherwise. So those are the main reasons we recommend not restarting the PACE program. Slide 46 talks about really some questions we'd like to add value to the study and not just say, hey, don't do this. We want to offer some alternatives. And really we want to look at is, can we recreate some of the valuable aspects of PACE without really going in the full risk managed care insurance product direction? We believe that PACE did offer very valuable services to the community in Cheyenne. We interviewed about 35, had very in-depth interviews about 35 former PACE members, and the perception and the reviews of PACE were phenomenal. They thought it was a wonderful program. It is very hard. We as a department believe that many fee-for-service services could substitute for PACE once it was discontinued, and that has turned out not to be the case. So, for example, transportation. We technically pay for transportation, but the uptake is very, very low in Medicaid. So PACE offered a very unique combination of services that work very well together. This adult day model with transportation to get to and from the adult day, as well as to all their appointments, the coordination of care that they could, everybody in that organization had eyes on people, right? The bus drivers, the CNAs, the physical therapists, the doctors, everybody, saw these people every single day and could kind of see how people were doing just visually, right? And that enables really in-depth care coordination. So there's some really valuable aspects of PACE that I think were lost. And that study will reflect that. On the flip side, there were, of course, things that were not valuable. So really the question is, are there things we can preserve? Is there some way to kind of bring back the real special sauce of PACE without going full PACE? The other question on slide 47 is, are there healthcare financing options that we could explore that would really encourage preventive care? And this is really kind of a fundamental problem on the public payer side between Medicare and Medicaid. So as many of you know, Medicare does not pay for long-term care much at all, right? They're very limited benefit post-hospital discharge. A lot of our feeder population, however, people that come into Medicaid long-term care are on Medicare previously, right? And Medicaid actually does offer what we call Medicare savings programs. We offer with basically a Medigap program for these seniors. And so we do see a lot of these folks before they enter our long-term care system. But we're just paying, in that role, Medicaid is really just paying the cost sharing components. We're just paying the real small part that Medicare doesn't cover. And so I think it's true that if the state had an incentive to really invest in prevention earlier and really try to work on coordinating Medicare on a fee for service, which can be kind of a nightmare to navigate for a lot of seniors. If we had that incentive, that would pay benefits 20 years down the road when we find these people and we're paying for their long-term care. So, but the problem is we don't have that incentive. Medicare is basically a faceless anomaly in Wyoming. It's all fee for service. It's run through Noridian, an administrative contractor. It's all fee for service. It works, I think, pretty well in that sense. But Medicare as an entity does not see people. They don't see people in a trajectory, and they just just to pay the bills for their medical services, right? So Medicare cannot really care coordinate in Wyoming unless you had some kind of managed care arrangement with a private company like a Medicare Part C, right? Medicaid, the state, we don't have an incentive to save Medicare money, because if we invest money on these seniors, that's just general fund that we're paying to save the Medicare program federal funds, right? So we have very little incentive to save them money. So right now there's a disconnect in those incentives. And if there's a way to kind of bring those together to have at least one entity kind of responsible for those preventive investments and also reap those gains from prevention, that might be something that might be worth exploring. So that's kind of just a broader philosophical question for this study. But we come to 3 policy recommendations on slides 48 through 50. These are more concrete, kind of going from those broader philosophical questions. The director specifically prohibited me from labeling these as mild, medium, and spicy, but they are small, medium, and large. Option 1, which is small, which is really kind of, again, we see these as a continuum, not necessarily replacing each other, but sort of different steps, depending on the will of the legislature, how you want to go. The small option is really looking at existing Medicaid services, specifically adult day services and non-emergency medical transportation. So those are kind of 2 of the core services that PACE provided. And we have very, very low utilization in both those areas. And the main reason is rate. We just pay a very low rate. And so we attract few providers. Rate increases to those specific services could be ways to increase utilization, right? So if we invest higher in those rates, we should attract more providers. There may be more people that utilize those services. So that's kind of a small option that we could pursue. I think there's also room to look at regulatory reform there, potentially working with stakeholders to say, okay, hey, what is hard about being an adult daycare center? What's getting in your way to setting one up and billing Medicaid for this? And there are staffing requirements, there are capital requirements, there's all kinds of things that are imposed both by Medicaid and our own Office of Healthcare Licensing and Survey. And maybe we could take a look at those, and there may be ways to reduce cost by looking at those regulatory efforts. But that's kind of in a nutshell our small option. Our medium option, option 2, is creating a new, we're calling PACE Lite service, which is really just a bundled per week or per day service. So we would basically say, okay, you provide the adult day, the transportation, pretty much most of what PACE provided, and we'll pay you a bundled rate on a per daily or per weekly basis. So it's not full risk. They're not going to be responsible for all the medical services. They're not going to be responsible for all the long-term care the person might use in the future. They're just going to be responsible for those very, specific services we'll pay for in a bundle, and that might help because we're packaging it all together, kind of create more utilization and more opportunities for providers to take that up. And then option 3, which is large and possibly crazy, but the idea is really looking at the state Medicaid offering a state-operated Medicare Advantage plan to its duals. So as many of you know, Medicare has both fee-for-service and the Part C or Medicare Advantage plan options. Medicare Advantage has always been operated by private insurers for the most part. This would be the state basically following those rules and becoming an insurer, as it were, and paying those Medicare claims. And so we would receive premium revenue from the federal government as part of the Medicare Advantage program, and then we would pay all the claims to Medicare providers. And that would give the state a very solid incentive to coordinate that care and make sure we're providing it as effectively as possible. And because we're going to be responsible for those Medicaid long-term care costs later, that's also giving us that incentive to try to invest in that preventive care right at that time. It also is likely to be budget neutral, both on the short term. I mean, there's obviously a huge learning curve, and this is something no state has done. It would be a very huge learning curve for our state Medicaid agency. Medicaid and Medicare are actually very different, have very different rules, surprisingly. But if it were successful, the profit margins for most of these Medicare Advantage plans is between 5 to 10%. So this could be a way to offset general fund directly. And there's also the possible payout of investing in the preventive services and receiving that saving money on the long-term care side at the far end. Now, this is just a German idea, possibly very crazy idea. Just wanted to give that as our option 3 or our large option. But it would be a way to kind of put all the financial incentives on the state. And so we would have sort of that ability to both influence the Medicare side before people reach long-term care and also coordinate that care as people age. So with that, Mr. Chairman, I know you all have a hospital to get to. I'm happy to stop here and take any questions.
You work very well under pressure, Franz. Any questions for Mr. Fuchs? Mr. Co-Chair.
Thanks. And I'm not sure how familiar everybody is, but the last couple of years with these Medicaid Advantage plans, there's been all sorts of allegations of fraud or overspending. I mean, there's certainly money there, and it just seems like such an interesting idea because of the state were to have it, you're not really allowed to commit those type of things that some of our private insurers can have some wiggle room on. I just wonder why no one's thought of having a state level kind of Medicare Advantage plan before. It is a spicy idea, but it could, it could be very effective and much cheaper than what I think, what did they say? I think it was Humana had a huge, like 20 billion or something they were making. And yeah, I don't know how to encourage you to pursue that, but we're planning on getting a full report kind of on all three of these options in October. And I guess we can go from there. I know there've been some small conversations with the co-chair. Depending how tomorrow goes on some of our more complicated bills, we may have another like 1-day meeting in November or Zoom only, depending on amendments and where they go tomorrow. So we could discuss, I think in November that time, but I guess I just encourage you to put full inquiry into what that would look like. Laboratory of democracy, our states.
I like small, grande and venti.
Yeah.
Okay, further questions, committee. Senator Hutchins.
Thank you, Mr. Chair. Franz, I love the way you present things fast. The spicy one, you say it will be extremely complex to implement. Could you get with the people that ran the program before to kind of help assist you so it wouldn't be so difficult?
Mr. Chairman, Senator Hutchings, so the option 3 has, there are no states that have done this before. We could certainly get expertise from the private sector, whether it's contracting it out and try to learn how to operate a Medicare Advantage plan. It's just the learning curve is going to be very steep. Sorry.
I think you didn't hear it. I was wondering about the people who ran the Laramie County program. Could you get with them to help you kind of get things flowing without it making it so extreme? Maybe more mild instead of so extreme?
Mr. Chairman, Senator Hutchings, I think certainly there's expertise there that we could look at. Yeah, and leverage.
Okay. Representative Warnock.
Thank you, Mr. Chairman. Question, maybe this more pertains to the report that is forthcoming, but will you include, or do you have information now on the PACE program specific to Cheyenne, because that's our base model, I assume. But how much money it took to fund that program initially? And then also the cost of continuing services with that. So it's based on the population of Cheyenne. And then secondly, also, I think a lot of us kind of talked in the past when we were looking into this, how, because Cheyenne's our biggest, relatively most dense populated area. When we talked about PACE, it was specific to what happens throughout the rest of the state, specific to these small communities and how that would be funded and what we can do to mirror that system in these very small communities oftentimes, and what the difference in cost, I suppose, is. I know that there was some private sector funding included with the initial PACE program in Cheyenne. So just, the information on the specific cost for that would be good. I don't know if you have that now or if that will be included in your report.
Mr. Chairman, Representative Warnock, it will be in the report. My understanding is that the CRMC put down at least $10 million as a capital investment in the PACE Center. That combined with, so we have some backup slides here, but we were looking at, hospitals, critical access hospitals, senior centers, nursing homes, anyone that deals with services with, provide service to this population. And really the only people that have that kind of magnitude of capital lying around, as well as the staffing to be able to implement the complexities of PACE, are a handful of larger hospitals and or wealthier hospitals. So we were looking at Cheyenne, Gillette, Casper, Jackson, and Cody, just to give you an idea of just the hospitals. The nursing homes and senior centers were all far down that list. So just based on who might be able to do it, just regardless of the rate, that's, it's a handful. I don't see PACE as being possible to replicate in small areas. It's just a very complex model, requires, they're responsible for everything, all inclusive, right? It's all medical, all long-term care. So if you need a specialist, you need to go to a nursing home, that provider has to have a contract with somebody to do that. It's not easy to do, just that factor alone. So we looked at those handful of hospitals, and there's been no interest from any of them in restarting PACE. So I don't know if that answers your question, but it's just an incredibly resource intensive program. It's very difficult to scale, especially in a state like this.
Okay, thank you, Franz. Committee. Next item on the agenda is to go visit the newest Wyoming hospital. Oh, a hand right. Next item on the agenda is to see what Anna has to tell us. Public comment. That's what she has to tell us. Somebody's got to keep the chairman in line. Do we have any public comment in the room?
Yeah.
Come on up.
Good afternoon, Mr. Chairman and committee members. My name is Rachel Settles. I'm the Executive Director for the Wyoming State Board of Nursing. Excuse me, I'm a little nervous. I would like to address a few of the concerns that Mr. Bully brought up, just so you're aware from our perspective as well. We did implement a new testing vendor for the CNAs in the state of Wyoming that went into effect July 1st. We currently have 5 testing centers in Wyoming to allow for the knowledge and skills testing. With that, we also incorporated knowledge testing virtually for the CNAs. We have reached out to multiple facilities for additional testing sites throughout the state. In regards to temporary permits, I believe there was some confusion in regards to allowing temporary permits. We do allow temporary permits through the State Board of Nursing for all licensees. The process right now I'm working on is for those licensees who were previously licensed in Wyoming and had never had one. I'm working with our Attorney General's office on ensuring we can offer those in the future. In regards to a career ladder, we do have many options throughout the state of Wyoming for CNAs, CNA 2s, medication aides, then LPN, RN, and advanced practice registered nurses. In my research over the last 2 years, the biggest factor for us in not getting those CNAs to LPNs and with those 2 other pieces with the CNA 2 and the medication aid is simply lack of knowledge. I'm working with my new practice and education consultant on how we get that knowledge out there through the state. And lastly, in regards to background checks, that is something out of our control, but is required for all of our licensees. Once we receive a completed application, we are able to issue a temporary permit if they meet the requirements while we wait for that background check. And sometimes that background check can take anywhere from 4 to 6 weeks. Again, out of our control, but we try to issue. We've recently been issuing licenses within approximately a month. So we're very happy with that as well. And I would like to let everybody know we are fully staffed. So back to our regular business as usual after some major turnover this year. I also have numbers for you in regards to licensees in Wyoming. At the end of the year in 2021, we had approximately 4,500 CNAs with the home address listed in Wyoming. And as of yesterday, we have 4,100. Again, that's with the address in Wyoming. That same number for RNs went from 6,900 to 7,200. It could say, we do not have the data for this, we're not currently collecting it, but it could say that those CNAs have progressed to the RN level. Those are just a few of the pieces I have for you. I also have a copy of all the numbers if you would like it, and I stand for any questions.
Very good. First of all, welcome to the Board of Nursing.
Thank you.
Number 2, don't be nervous in front of this group because you're probably smarter than all of us. So relax. You did great. I believe that Senator Doxler has a question.
Good presentation. You touched on temporary licenses. What would you pursue there? Who are you going after and how long would it take and where could we put them?
Go ahead.
Mr. Chairman and Senator Doxler. Currently, we are able to issue temporary licenses for those who are currently waiting to test, whether it's for their national exam or their CNA exam, and for those who are endorsing in while we're waiting for their background check. The struggle I'm having right now is for previously licensed people in Wyoming. So a CNA comes in, they were licensed and they let their license lapse or expire. can we issue them a temporary permit when they apply for relicensure? Currently, I'm having our Attorney General's office look into that with our board rules and our Nurse Practice Act. Once that is approved through them, I will be working on ensuring we can move forward with our licensing system to implement that.
Thank you.
Questions, Representative Warnock?
Thank you, Mr. Chairman. Give us those numbers one more time, and then I'm curious, do you have some type of idea for the historical numbers that have you seen an increase in licenses, or are we steady? Are we decreasing over maybe 10 years? I don't know, but could you give us those numbers one more time? Thanks.
Go ahead.
Mr. Chairman and Representative Hornock, yes. I can even pass that out. I brought enough copies for everyone today. I only pulled data from the last 3 years, end of year 2021, end of year 2022, and then as of 2023. I would be happy to attempt to research further data. Our licensing system we implemented in 2018, so I could for sure go back 5 years. I'm not sure about the previous ones, but I could work on that for you. For CNAs currently with a home address in Wyoming, we do have a total of 4,108, and that was as of yesterday. Overall licensee total, we have 4,525. That is could be related to individuals who live in other states and work in Wyoming. CNAs do not have a compact, so they must be licensed in Wyoming to provide care in Wyoming. At the end of the year of 2021, we had 4,500. So we do have a small decrease at this time, 3 months left to go and we're issuing licenses currently. But at this time, there is a small decrease of 400 from end of year 2021. The difference in that is our nurses with the home address in Wyoming have increased from 6,900 at the end of 2021 to 7,232 at the end of yesterday. So there may be a difference in just that progression from a CNA to an RN. I also included in here our end of year numbers for 2022. There's a slight difference on that, and it could be attributed to it's our renewal year. So you could see a decrease at the end of 2022 when our licenses renew. Some people do not let them or do not renew them. For example, a CNA that has now progressed to an RN or even an LPN, they can hold dual licenses, and then they may let that CNA lapse at renewal time.
Very good. Follow-up with slow follow-up. Go ahead.
Yeah, Mr. Chairman, thank you. No, I'm sorry. I kind of lost my train of thought with the numbers. Yeah, never mind. Thanks.
He'll catch you offline. Okay, further questions? Quick question, Senator Hutchins.
Thank you. Very good presentation. On the licensure, you had CNAs, RNs. Why would someone want to keep dual license if the CNA is below the RN, an RN can do what the CNA can do? Explain that to me.
Go ahead.
Mr. Chairman, Senator Hutchings, simply because your license doesn't expire when you receive a new license. If you are a CNA, as you're going through school, you can keep that CNA certificate active until you get your new license. It doesn't automatically expire when you receive your your next licensure up. From my personal experience, I did that with my CNA, received my LPN, but had them both. Let my CNA expire, kept my LPN. When I received my RN, that had both of them for a short amount of time, and then had just my RN.
Right.
You're welcome.
Very good. Oh, his train of thought came back in the station. Go ahead, Representative.
Thank you, Mr. Chairman. Reciprocity. If somebody moves from another state, what's the process for them to get licensed in Wyoming? Is it just kind of a rubber stamp deal since they were already licensed in another state, or do they have to go through the whole licensing process again? What's your current method on that?
Go ahead.
Mr. Chairman, Representative Hornock, it depends on the licensure. For an RN and LPN, we are part of the Nurse Licensure Compact. So if they were to have a multi-state license in another state that is part of the Licensure Compact, we have 40 states that are part of that. They can move into Wyoming. There is no timeline on when they need to transfer their license to Wyoming. If a CNA or APRN where there is no compact were to move into Wyoming, they do have to start the process of licensure. However, if they've never been granted a temporary permit for that license, they can receive a temporary permit as soon as we receive a complete application, which includes their fingerprint cards, payment, and proof of competency. That usually is issued once we receive a completed application within 3 days. And then we wait on the background check to come back, and we are able to issue a license within 4 to 6 weeks at the longest.
Okay, thank you very much. Again,
Thank you.
welcome.
Thank you.
We'll be seeing a lot of you. You'll be seeing a lot of us.
Yes, you will.
So
Thank you.
thank you very much. I believe that's Mr. Laycock sitting there. He's a halo when you're sitting this way by the back window. Go ahead, sir. And we know you really don't have a halo.
Maybe not to you, but Mr. Chairman, Tom Laycock, Associate State Director for AARP Wyoming. I want to thank Donna for the great job putting together the memo to really frame the conversation around older adult services that we have in the state of Wyoming. As one small note, she mentioned, she referenced the Across the States long-term care study that AARP does every 3 years. The next one will actually come out on September 28th. I've seen a preview of it. Unfortunately, we've dropped in our rankings from 33rd in the country down to 40th, and I'll give you guys a kind of an update on what that looks like at a later date. So what I wanted to talk about was just to offer a couple comments on the 1115 that you see ahead of you. The Healthy Aging Data Report dropped last week. Tells us older adult population in Wyoming is swelled by more than 45% from 2010 to 2020, making it the Wyoming 65 and over population, the fastest aging group in the state. The good news is 61% of our older adults are in the young old category. That's 65 to 74, which means less likely to use services, which means we got a little bit of time to figure out how to divert care to home services, which is less expensive from the state than this for the state. We appreciate the work the department has put into the 1115 application, and overall, we think it's a pretty strong proposal. We believe it supports an intent to keep people aging in the community and is consistent with AARP policy, though we have a couple concerns. As the Department of Health has mentioned in previous meetings, Medicaid funding accounts for around $130 million per year in long-term care, and that's both home health services as well as skilled nursing facility admissions for those who cannot afford those services on their own. That spend is predicted to rise to nearly $250 million by 2038. Now, right now, it costs about more than $4,900 per person per month through the Medicaid system to put someone into a nursing home. The design behind this particular 1115 would aim to lower that cost by using home services to an average of $1,100 per person per month. That's real savings to the state in a setting where people really want to be covered. AARP would like to understand where the 1115 might fit into the existing suite of long-term services and supports in Wyoming. The concern is we would like to see the 1115 used as an evaluation tool for home services and not the sole home service program for those non-Medicaid eligible. In other words, we'd like to see a combination of the 1115 while maintaining the Wyoming Home Services Program, which offers a much lower level of service than the proposed 1115. One of the common questions we've gotten from lawmakers regarding home services over the years is, how do you know this works? We think the 1115 could go a long ways towards answering that question. However, the randomized controlled trial process proposed for the program evaluation concerns us. We do wonder if one, it makes sense to ask for more data reporting from WISE providers to seek greater clarity on the effectiveness of programs. And we would suggest patient satisfaction surveys in addition to metrics such as institutional diversion. Two, we're not aware of many, if any, states that are using an RCT to prove cost neutrality to CMS. We'd be interested to know if there are other states who do this method, and if not, why. And three, the fear is that the randomization could work against the program politically. If someone who needs services is told to wait, and a neighbor who applies for services at a later date is served sooner, political pressures could undermine the effort to get the data the department seeks as part of the program evaluation, and that's an evaluation that we want as well. I do want to offer my compliments to the plan as well. At AARP, we're big fans of self-directed services. That's the philosophy that we talked about earlier about being able to hire a neighbor, hire a friend when it's appropriate for things like chores, rides, things along those lines. We'd love to see the non-medical transportation added to that list of eligible services in the 1115. Also, our experts in long-term care have told me that multiple 1115s have allowed for those, covering those who are presumptively eligible for Medicaid as well. This means getting services to someone who needs it before the Medicaid paperwork is completed. In the past, if a state puts someone on presumptive eligibility, and then it turns out they were not eligible for Medicaid, the state was on the hook for that extra money. I'm being told that CMS no longer requires states who guess wrong to pay back what Medicaid has already paid on that client. Our final comment is to thank the department for applying for a higher Medicaid eligibility threshold and the increase to asset threshold. Removing the asset recovery is also a welcome component of the waiver application. So in closing, as always, we appreciate feeling like we have a strong advocate for home services in the Wyoming Department of Health. To develop a program like the 1115 from scratch is a tremendous intellectual exercise and is being done for all the right reasons. We thank Franz for the work put into this project and for being genuinely curious if there's a better way to help our older adults age in place. So with that, I'd stand for questions.
Questions, committee? Is the train in the station? Go ahead, Representative.
Thank you, Mr. Chairman. You gave a number of $1,100 basically for, I assume that's the average for home services per month. Can you give me an idea of what that includes? What type of services does that cover?
Sure. So as you saw the PowerPoint that sorry, Mr. Chairman, Representative Hornak, as you saw that sort of two-columned presentation that Franz had up there on his PowerPoint in terms of covered services to the left, not covered to the right, you're looking at the ones on the left. So once again, that would be, is that Franz? I might defer to you on this a little bit too. Lest I say something incorrect.
Mr. Chairman.
Go ahead.
Representative Warnock, that's slide 32 on our omnibus presentation. So it has two tables. The services on the left would be covered by this waiver and the services on the right would not. And the average per member per month cost is, we estimate around $1,100 PMPM. I'm happy to talk to any of those services if you like.
Good. Okay. Committee, further questions? Okay. Barring, thank you very much for coming. Barring that I'm messing up again and LSO has to correct me, our next project is going to the newest hospital in Wyoming, the Platte Valley Medical Center. Directions are really straightforward. There's a map if you want to look at it. Go ahead if you want to. It's pretty simple. It's on Bridge Street, straight east. It's up here on the end of Bridge Street. Bridge Street being just over this side. It's called Bridge Street because it crosses the river over a bridge. It's just right down here where the Wolf Hotel is. That's Bridge Street. Get on that street and go up the hill up here and it's right at the top of the hill. Don't go to the bridge, go the other way. If you go over the bridge, you went the wrong way. And if you're lost, follow me. It's easy to find. Okay, with that, we will stand at recess until tomorrow morning at 8:30. Is that correct?
That sounds good.
8:30 a.m.